Hi, I'm Dr. Derek Lee. I'm happy to introduce Dr. Ron El-Hawary, who's the Chief of Orthopedics at IWK Health Center in Halifax, Nova Scotia. He's also a professor in the Department of Surgery at Dalhousie University. He's currently the president of the Canadian Pediatric Orthopedic Group and president of the Children's Spine Foundation and president of the Pediatric Spine Study Group as well. I could go on, but welcome, Dr. El-Hawary.
Thanks very much. Appreciate it.
Okay. Just to have viewers get an idea of where you came from, and I'd like to always talk a little bit about your career path, because yours is a little bit unusual in terms of you were a mechanical engineer to start with before you moved on to medicine and to become a spine surgeon. How did that happen?
Oh yeah, great question. I think everybody's path towards their ultimate career can be interesting with lots of twists and turns. I grew up in a family of engineers. Mom and dad were professional engineers and worked as professors through various universities, most recently at Dalhousie. And my older brother is an engineer. So kind of in the family, I guess. I'd always been taught that engineering is a great undergrad to have. You can get a fantastic job as an engineer, or if you wish, it can be used as a foundation towards other careers such as medicine, law, or business. But also, I'd always had an aptitude towards physics and math. So for me, engineering was a natural fit as I started my undergraduate career. And I had thought I might go into a field such as aeronautical or aerospace engineering. But during one of my summer jobs, I had a chance to work with an orthopedic surgeon in Halifax, and I did some biomechanical testing with him. And that really opened my eyes to the field of orthopedic surgery and the mechanical nature of orthopedics, which went hand in hand with mechanical engineering. I'd also felt that development of innovative medical devices could be of interest to me in the future. So from that, I applied to medical school and completed that at Dalhousie here in Halifax, Nova Scotia. And then I did my orthopedic residency at University of Western Ontario in London, Ontario. And then did a couple of years of fellowship, one at Western in pediatric orthopedics, and then one in Dallas at the Texas Scottish Rite Hospital for Children, where I did further training in pediatric orthopedic surgery and had an emphasis on scoliosis surgery at that time. So I guess that's where it all started, was the influence from my family with that engineering perspective, and I think I tried to utilize my fundamental engineering knowledge towards my everyday activities, both clinically and certainly through a research perspective.
So would you say you're deep down an engineer at heart, then a doctor, in terms of, what's the order in terms of priority for you?
Yeah, I mean, that's a great question. I would say at heart, the way I did identify myself, it would be a surgeon first and foremost. Mm-hmm. And I think what makes me unique amongst the orthopedic surgery community is that engineering background. And others in our field have it, and I think you'll probably be speaking to a couple of people through this series that also have a biomechanical type of background. So I do identify with that, but I think if I had to pick one, yeah, I'd be as a surgeon.
Well, there you are. Now, with your fellowship at Scottish Rite in Dallas, Texas, did you ever run into Dr. Tony Herring and Dr. Peter Newton, being in San Diego, that area?
Yeah. So Tony Herring, he was the chief of orthopedics at the Texas Scottish Rite for years and years, and he was the professor and head of orthopedics at the time when I did my fellowship. So I worked very closely with Dr. Herring. He's certainly a very important mentor to me. And I'd also had a chance to work quite closely with all of the surgeons there, and they're all mentors. And their current chief of staff now is Dr. Dan Ciccato. And he especially had taken me under his wing and helped me develop some more advanced techniques in scoliosis surgery, including thoracoscopic surgery, which at that time, he was doing a lot of thoracoscopic releases to try to improve the flexibility of scoliosis curves in really large, severe, stiff curves. And he's also performing thoracoscopic anterior spinal fusions. So he's the person I'd credit my ability to do thoracoscopic work, including vertebral body tethering. And at that time, this was in 2004, 2005, Dr. Sakato had the foresight to recognize that vertebral body tethering was being developed at that time and was on the horizon. And he was a large influence on me to keep up my thoracoscopic skills throughout my early career, knowing that VBT would be on the horizon. So even though I did not do any VBTs, most people hadn't until just the last several years. And I think my first surgery was probably 2016. I think I'd have to look back. But those first 10 years of my practice, I wanted to keep up with the thoracoscopic techniques that were taught to me by Dr. Sakato, and that involved doing, close to 100 thoracoscopic releases. And with those surgeries, are combined with a posterior spinal fusion and instrumentation as well. But that kept me very active with the scope and knowing those techniques, again, knowing that VBT was on the horizon. The other person you mentioned, Dr. Peter Newton, he did his fellowship at Texas Scottish Rite Hospital. He was a few years ahead of me, and he was already in practice in San Diego at the time of my fellowship. And I was certainly also tempted to potentially do fellowship in San Diego, knowing the great reputation that they had there. I was given an opportunity through the Scoliosis Research Society to visit a surgeon early in my career and spend about a week with him. And with that award, I asked Dr. Newton if I could spend some time with him. And I had a chance to be in the operating room with him and observe his techniques for thoracoscopic surgery. It was a fusion technique. Again, this is pre-VBT. But I think I was able to get almost a second mini fellowship, even in that short week with Dr. Newton, just seeing how you can use the scope a little bit differently than the way I'd learned to use it before. So he's also been a huge influence on me over the years, especially through the Scoliosis Research Society.
Very good. And I know quite a few, well, Dr. Miangi was a fellow with Dr. Newton as well. So it's a small world in the spine fusion surgeon. Yeah,
it really is. Absolutely.
Now, with the thoracoscopic approach, I'm beginning to learn that it's not a readily accessible technique to a number of spine surgeons, especially for fusion. They tend to do the traditional posterior approach, and funny enough, I was also interviewing Dr. Herring, and he was saying that over the last 10 or 15 years, the anterior approach for fusion has kind of gone by the wayside, but he anticipates it'll be coming back around again as I guess trends come and go. Do you also see that as something that's might be ahead, coming soon as well?
Yeah, I agree with you 100%. The anterior techniques to treat scoliosis, it involves a special skill set, and not every pediatric spine surgeon is trained for anterior surgery. As a result, it's only limited to certain centers that have had the training. And in Canada, I think that's Halifax, Montreal, Ottawa, and Vancouver, and now Edmonton, I think. And that's in no particular order, I think. That it is expanding again over time, whereas a couple of years ago, there was nobody in Ottawa and Edmonton doing it. So I think you can see it in our geographically large but small populated country. It's increased by 30 to 40% over the last couple of years as people are learning it again. And as more surgeons are using it, then the next generation of surgeons that are training with us will learn those techniques. I think for maybe a 10 or 15 year period early in this century, there's a lot of enthusiasm for doing a lot of the work posteriorly rather than anteriorly. One of the reasons to do the anterior surgery was to do what we call releases, where you remove some discs and relax a few ligaments there to get a really severe scoliosis that's stiff, a little bit more flexible, so you can get more correction. There have been some techniques where you can remove bone posteriorly, what are called osteotomies. So through a posterior approach, you could loosen the spine as well and get a great correction. So because of the enthusiasm for doing those releases posteriorly, not as many surgeons were doing the anterior work. So it had become, you know, an art, not a lost art, but kind of on the way to becoming a lost art. And I think thanks to the interest in the development of VBT, which, as you know, has been ongoing for the last 20 years since the first animal studies were performed, more surgeons are utilizing that approach. And I think it's very important to know that approach. And if you as a pediatric orthopedic surgeon, spine surgeon, don't know the approach, and a lot of fantastic, highly capable surgeons are in that category, you can still safely do the vertebral body tethering if you work with another surgeon who has those techniques. So for instance, pediatric general surgeons, pediatric thoracic surgeons, they do work in the chest very routinely with a thoracoscope. So some models of care in some places in the United States have been to have what's called an access surgeon. So that might be a thoracic surgeon or a general surgeon who is familiar with the anatomy anteriorly and can help out with their thoracoscopic part of it. And with that access to the spine, then the pediatric spine, orthopedic spine surgeons are able to put in the implants for the vertebral body tethering. But I think it's super important that you have the appropriate training, the appropriate people that are doing this technique, because it is a highly specialized technique.
If you're going to, off the top of your head, estimate what percentage of pediatric spine surgeons have that skill set with the anterior approach, what number would you throw out there?
Oh gosh, yeah, that's a good question, and it's an estimate. I don't think anybody has that data at their fingertips. If we look at Canada, for instance, the centers that are listed that have that capability, that represents probably about 40% of the Canadian pediatric hospitals. So I think in Canada, we're probably overrepresented with it. It's usually just one surgeon in each of those centers, and all of those centers have between 2 and 4 or 5 surgeons that do pediatric spine surgery. So I'd say the true number, if you look at it by percentage of surgeons, would be less than 10% in Canada. Mm-hmm. And in the United States, probably less than 5%.
Okay. So it is a skill that, because I've heard from other surgeons who do the procedure that it does take quite a bit of time and quite a bit of expertise in order to really master that. Okay.
Absolutely. And I think a lot of, I think a lot of highly skilled pediatric spine surgeons that aren't doing VBT right now, that might be able to learn the technique or use an access surgeon to help them out with it. They're waiting to see some of the results of the early cases of VBT before they adopt it. With new technology, there's something called the Moore's diffusion theory, in which it's a bell curve in terms of the number of surgeons, or time is on the x-axis, the number of surgeons utilizing it is on the y. Mm-hmm. So when you're starting a new technique, over time you have very few surgeons that are doing it, and those, with VBT would be surgeons like Peter Newton, Amr Samdani, Randy Betts, that were the very early ones doing it. Then you have the early adopters. Those will be surgeons, in Canada, such as Feroz Mianji, Stefan Perrant, and myself, and then more surgeons. And then you get the early adopters, and then you get that peak where you get the majority of people doing it, and then trails off over time to the last surgeons that adopt that technique. So the old surgical paradigm has been, you never want to be the first one to do a technique, but you don't want to be the last either. So I think we're at that phase relatively early on, where those early pioneers have trained surgeons such as myself, and now we're early adopters, and it's our job to perform this as responsibly as we can, and that's with patient education, patient selection, analyzing our results, looking at complications, being honest with our reporting, and disseminate that information to our peers as well as the patients over time. And as that gets out, the technique ultimately gets better and better over time, and then more surgeons will use it. So we're still fairly early on in the development of this.
And you also have some experience with vertebral body stapling, I believe, correct? And
yes, I do.
And initially, I guess for the first 2 years, results were promising. Then after about 4 or 5 years, the procedure, I guess, wasn't as, results weren't as great. VBT is kind of on that same curve where the first couple of years, we're seeing good results. How do you see VBT in terms of the promising results for future, that type of thing?
Yeah, I think that VBT probably holds more promise over the long term than the early stapling series that we've done. I think it all comes down to refining what the indications for an operation are. So if you have a theory and you develop a device, you study it in animals, then you start clinical studies with it, you don't really know what the limits are in terms of the size of the curve from small to large, the age of the patient from young to old. So as more patients are being treated with it, we refine those indications. So then we recognize that, okay, this is the age group that it could work in with the growth remaining. This is the size curve, flexibility of the curve that it could work in. And with stapling, the indications changed to the point that it was such a narrow subset of patients that it might benefit, that it would be patients where scoliosis was between about 25 and 35 degrees. So that's a pretty narrow window of opportunity. Whereas initially, when I'd started using the staple technique, it was felt that it could be used in curves as large as 40, even 45 degrees. And it became clear with longer term follow-up that those cases didn't do as well. The staple may not have been as powerful as we would hope for those larger curves. And I think it could work great in 25 to 35 degree curves. The dilemma is that those are also curves in which a brace can be 75% successful. So the cases in which I've performed the stapling in the past has really been an alternative to bracing. So if somebody is being treated with a TLSO style brace and isn't able to comply for one reason or another, and there can be a multitude of reasons why bracing may not be effective for somebody, then I would transition to stapling. I don't usually start bracing unless it occurs over 25 degrees. I try to follow the guidelines of the Scoliosis Research Society. So if you recommend bracing and somebody tries it and the curve gets bigger despite bracing, or the patient's not wearing their brace, by the time they're ready for another alternative, usually the scoliosis is greater than 35 degrees. So it's just a really narrow window of opportunity to hit. Potentially over time, depending on, I guess, attitudes of society, et cetera, towards something like a brace that is external, it's visible to other people. It's a huge time commitment in terms of number of hours per day and the number of years you have to do it, versus, you know, a quick fix of a surgery. You know, maybe patients might be more interested in going right to a surgery, such as a vertebral body stapling, without even trying a brace. I don't think we're there in Canada right now. That might change over time. And, you know, I think if it were one of my teenage daughters that was being asked to wear a scoliosis brace, if they had a scoliosis in that range, I would choose a brace first over something like a vertebral body stapling. If it didn't work, then yeah, you could consider it. But I think my experience has been reasonable with the vertebral body stapling. I think it's just evolved to such a narrow window of opportunity for it to be effective that it's difficult to have patients in that window if they try bracing first, and also in the Canadian healthcare system where there are some constraints with OR access.
What was your first access to VBT, or when did you first hear about that? And I recall you saying that even in San Diego, you are aware of VBT and that you're trying to keep up your skills with the thoracoscopic approach?
Yeah, I first heard about the potential for VBT in 2004, 2005, when I was doing my fellowship in Dallas. I had read the animal studies that were performed, and I recognized that there was a proof of concept in an animal that you can induce a scoliosis by putting in the tether technique. So I was aware of it at that time. In terms of it being utilized clinically, I followed very closely the early results from the group in Philadelphia, Amr Samdani, and at that time Randy Betts was the head of their group there. And once I was able to see some of the 1 and 2 year results, I think that gave me the confidence to consider doing VBT. And of course, doing a new procedure, even though I had the skills with the thoracoscope, I had the skills of putting in a screw into a vertebral body through the thoracoscope. There's some other nuances in terms of putting in the actual cord or tether itself and how to tighten it and tension it. That's always a good idea to get a refresher or learn from somebody else. And I took the opportunity to visit Stéphane Parent in Montreal at St. Justine Hospital. And I was able to assist with 2 of his VBT surgeries there, and learned a few more tricks, and was able to come back to Halifax and start doing VBT.
Do you have a general parameters, perfect parameters of your VBT patient?
Yeah, it's a great question. It's for me, it'd be an idiopathic scoliosis, either juvenile or an early adolescent infantile scoliosis. Generally, at least 10 years of age. They may have been diagnosed in the juvenile age group, but I think for the most part, it's probably a little bit too powerful to treat young kids with it, that you might overcorrect. For me, it's mainly been thoracic scoliosis, what we call a Lanky 1 scoliosis, so just a thoracic without any lumbar component, and curves, between 65 and 70 degrees would be the upper limit. The lower limit might be as low as 35 degrees, depending on the age of the patient and remaining growth. Flexibility, I think, can be important, but currently it's not one of my key parameters for VBT.
Okay.
In terms of how much growth remaining, you can look at it either with the RISR staging or with the digital skeletal age, a Sanders score, for instance, and RISR 0 for sure, RISR 1 in certain cases.
And Sanders would be 3 or 4?
Yeah, 2 to 5 is kind of the range. So yeah, very, very close to yours. Again, these are very, if you say it's just going to be a Sanders 3 or 4, it's really hard to kind of diagnose it at that time and recommend surgery and get to the OR where it's still in that category. Mm-hmm. When I started doing VBT about 4 years ago, we were doing them on RISR 2 and even some RISR 3 type patients as well. So that's all part of the learning curve to show that if you want true growth modulation, sure, you can put in a VBT in anybody, even if they've stopped growing, and you get a great correction of the scoliosis in the OR immediately post-op, but you're not going to get any more growth modulation or correction over time. So I think if we truly want to use it as growth modulation, and I think currently that's the philosophy throughout Canada anyway, and that's fairly pervasive in the United States, save a couple of centers that you'd want to do that, less than Sanders 5, so you have that growth modulation effect. We're now looking critically at, how much correction we get on the table, and is it truly growth modulating over time? And if after 2 years, it's, maybe you bring it down from 60 degrees to 25 degrees in the OR, that's awesome. But if it comes down to 15 or 20, a couple of years later with growth modulation, yeah, that's fantastic. But is it worth the extra 5 or 10 degrees?
Absolutely. because that's the thing. And I know certain centers are trying to develop predictive software or predictive tools in terms of how much growth modulation is anticipated, but it's so difficult because it depends on tether tension, so many variables, such an art still. Now, I was wondering if we could hop over to Apifix. Now, you were the first surgeon in North America to have access to that technology and to use that, perform that surgery. How did that come about?
Yeah, it's been interesting being involved in its development, and full disclosure, I am a consultant with the company, and I try to be as unbiased as possible, but that should be on the table first and foremost. I was at the International Congress for Early Onset Scoliosis meeting. It's an annual meeting that the Children's Spine and Growing Spine Foundations put on every November. And it was in Boston that year, and I think it was probably 4 or 5 years ago, and I was asked to be part of a focus group to look at Apifix. They invited about 20 pediatric spine surgeons that were at that conference to come in to hear about the device, to see what their outcomes have been in Israel and in Europe, and to learn more about it. And this device, just for the viewers who may not know what it's all about, it's a posteriorly based device. And that's, I think, really attractive to pediatric spine surgeons. Again, you'd asked the question about the percentage of spine surgeons that do any anterior work. It's a relatively low percent. We all do posterior work. So if there's an alternative, fusionless alternative that can be done posteriorly, I think that's probably way better for the patients over the long term. And if there's a device that can be proven to work and can be utilized by any pediatric spine surgeon who knows how to do the posterior approaches, by default, that's pretty much everybody, that's the way to go. So I think that was the main catch with this is great, it's posterior. Again, going back to my teenage daughters, I think if there's a fusionless procedure and there's a choice in going anteriorly, thoracoscopically, or doing it posteriorly, I would choose posterior, if everything else being equal. Mm-hmm. And I think I'm in a unique situation right now where I utilize the Apifix for certain patients, and I do VBT for certain patients. And I really try to rationalize it and think about each patient as an individual, look at the results of studies and decide which is the better option for that patient, and have some shared decision-making around it. And I think that helps alleviate a lot of the potential bias with working with a company, is that I'm not just directing everybody towards VBT or directing everybody towards Apifix. It's a bit of both. But going back to the initial response at that time, it's a device that's put in posteriorly. And initially, when it was first introduced by the surgeons in Israel, it was just at the apex of the curve, just over 3 or 4 segments at the apex or most curved part of the thoracic spine, or in the lumbar spine. And that's where the API from the Apifix comes in from apex. And it's really just 2 screws with a rod. And when we see just 2 screws and a rod as pediatric spine surgeons, we think about the Harrington rod, which was developed by Paul Harrington in the 1950s and was the first generation of instrumented spine fusion for scoliosis. And that was a very revolutionary. We still refer to Harrington rods all the time. And they work relatively well for a lot of patients. But the problem was that if you have a rigid rod with only a couple points of fixation and you have movement over time, often the rods will break. And that was our first response to the Apifix, is, oh my gosh, it looks just like the Harrington rod. Is that any better? But that's where my engineering side of me came out and said, okay, well, what's unique about this? What makes it different than the Harrington rod? And what's unique about it is that there's some what we call polyaxiality of the screws. So where the screws meet the rod, you get some movement. So if a patient is running, doing sports, rather than the rod kind of being fixed between screws, either the screws are going to pull out or the rod's going to break, because there's some movement between the rod and the heads of the screws, that dissipates or dampens the force. The likelihood of the screws migrating or the rods breaking is a lot lower theoretically. There's also some unique characteristics with the materials that are used for it. But suffice it to say, it piqued my interest from the engineering perspective to see how this device could potentially be better than a Harrington rod and not have device failures like a Harrington rod did, yet allow a fusionless surgery and allow the best mobility possible. So I spoke to them again afterwards, and they invited me to talk to them in some detail about the engineering aspects of things. So now this is kind of a one-on-one meeting, or I was the only surgeon with a couple of members of their team, including their chief engineer. And they were very open with sharing their biomechanical testing that they had performed, and very open with sharing their early clinical results. And they knew it wasn't perfect at that time, but wanted some people to help out with the development of it to try to make it better and better. And that's where I have been helping them with some of the design of it, as well as some of the clinical parameters. So what's evolved over time now is that it's still posteriorly, but rather than just 2 screws, we use either 3 or 4 screws, and we span more segments. So rather than just the 3 or 4 segments at the apex, it's usually between 5 and 7 segments posteriorly. And we have the device in place that, again, has that mobility between the screw heads and the rods. And it can actually expand over time with certain exercises that you can do. So you get a little bit more correction over time. So that's how I got involved in it, and kind of how things evolved over time. And in 2017, I was able to utilize it here in Canada through special access with Health Canada. I was able to identify a couple of patients that were interested and met the indications for the device at the time.
Great story, and it's finally nice to get the background, because it's interesting how a new technique is introduced into a different country at the very least. What was the reason for going to spanning just the apex to larger levels, longer levels, and the reason from going from 2 screws to 4 screws, or 3 to 4 screws?
Yeah, great question. I think the reason for going to 3 to 4 screws is related to spanning more levels. So I think to span more levels, you need to have a little extension on the device. And with the extension, you have the ability to put in a second screw, so you get a little bit more fixation. So I think the answer I'll focus on is related to why go 5 to 7 segments rather than 3 to 4 segments. And that's related to analyzing the results of the European and Israeli patients, looking at the number of levels spanned versus how much correction of the scoliosis. And we studied this, and we were able to publish it in January of this year, that the correction of the scoliosis was improved by spanning it to 5 to 6 levels versus 3 to 4 levels. And that is measured by the percentage of patients whose scoliosis ultimately ends up being less than 35 degrees, and now even less than 30 or 25 degrees. It's been shown that by spanning more segments, you get more correction, and that's the main reason why.
I've also heard that in certain circumstances that you do selective fusion of different segments as well, when you're incorporating the Apifix device. Can you talk about that?
Yeah, absolutely. It's just one level typically that we just do that fusion. And, you know, it's often around the 5th and the 6th thoracic. So part of the spine doesn't have much mobility anyway. And with the device, we talked about the movement between the screw heads and the rod that dampens the force. But with putting in 2 screws, so we typically would do 2 screws at the top of the device and 1 screw at the bottom. The bottom one is fine. That doesn't need a fusion because you have that mobility between the head of the screw and the device. But now if you look at the top of the device, where you have the extender rod on the top, the movement between the device is between the extender rod and the screw head that's down here. So that ends up with a rigid segment between the heads of these two screws. So then you're back to the Harrington rod scenario where you have two screw heads fixed firmly to a rod, and that could break over time. So because of that, it's wise to do just a little local fusion just at that one level. So again, that's one level out of the 12 levels of the thoracic spine in an effort for that tiny extender rod not to break. And I've heard a few patients and families express some concern over that okay, is it truly fusionless? I guess it all depends on how you look at it. It's a technique that we utilize for children under the age of 10 with what we call early onset scoliosis. These are the kids that are treated with growing type rods, such as the magnetically controlling growing rod, and there's some other variations on that as well, where we are just putting in a cluster of screws or hooks, at the bottom of the curve and a cluster at the top of the curve. And we always fuse those, we call those foundations. So it's really important to have a nice solid foundation for your implants, which are usually screws, to be able to support those rods. So if you don't have that solid foundation, then you could run into some mechanical issues.
Okay, that makes sense. How do you selectively fuse those segments, that particular one level? Is there a specific technique that you do?
Yeah, it's the same technique that we do for long fusions as well. So we always think about the rods doing all the work of the fusion. The rods are really just there to hold the spine in the position that you want until the bone knits together into a solid sheet of bone. So to be able to allow the spine, and in this case, just the one level, to fuse together, you take off the hard outer shell of the bone. So remember how the bone has that outer shell that's called the cortex around it? That's the hard part. You can kind of knock on it, think about a chicken bone or something. And then the inside, it's more of that cancellous or spongy type bone. So if you have hard cortex bone at one level and hard cortex bone on the other, that's never going to knit together even with fusion rods in place. You can put bone graft on top of it and hope that it's going to fuse together, and that might work. But we usually do a combination of taking off the hard outer shell of the bone, taking off the cortex. That's called decortication. So we do that at one level, we do that at the other level. And then we put in bone graft to kind of bridge that gap. And then over time, the bone incorporates.
So the disc isn't really touched in the posterior fusion then at all, right?
Exactly. Yeah, that's a great point. It's just a posterior fusion.
I was wondering if you could go over the parameters for Apifix in general. Then I'd like to dive down into that a little bit more.
Yeah, absolutely. It's again, just like VBT and vertebral body stapling, it's been evolving over time. And through that learning curve, this is helping my patients. So some of the patients I might have treated in 2017, 2018, those curves might be too large or too stiff. That is, they came through my office in 2020, 2021. You might say, the Apifix may not be right for you. And again, that's all part of the learning curve with any of these technologies. The Apifix in Canada is not Health Canada approved at the moment. It's for special access, so we apply to Health Canada for permission for specific patients. In the United States, through the Food and Drug Administration, through FDA, as I'm sure you know, VBT was approved for certain regulatory pathways last August, and 2 weeks afterwards, Apifix was also approved. So currently in the United States, there is a post-approval study, and those patients have to be treated at certain centers. So right now there's 20 centers in the United States that have been demonstrated interest in the technique and are being educated on the technique, and we're helping out with some of that surgeon education as well. And through that post-approval registry, all those patients will be studied through the pediatric spine study group, and all of their information de-identified, of course, as a research study. But we're looking at their health rate, their quality of life. We're looking at their pulmonary function test. we're looking at the scoliosis and several other parameters, tracking any potential adverse effects. That's all being housed in the pediatric spine study group database. And we're looking at 200 patients. That's the commitment to the FDA, is 200 patients through this post-approval pathway. So once those first 200 patients have had their surgery over the next year or two, those results are evaluated and presented to the FDA to see if it is potentially available for a full approval. And I think that's a similar pathway to what's happening with the vertebral body tethering as well, but I'm not as intimately involved with that process. So I know it's a roundabout answer, but I'll get to the direct answer to your question, is that currently what the FDA approvals are for that study for Apifix is adolescent idiopathic scoliosis, so no adults. And it's for either a Lenke 1 curve, so that's just a thoracic curve by itself, or a Lenke 5 scoliosis, that's just a lumbar curve by itself. You can't do double curves, so it's either a thoracic or a lumbar. And the curve magnitudes are 35 degrees to 60 degrees, with flexibility on a bending or a stretching x-ray to less than or equal to 30 degrees. And that's really key with the Apifix, is that flexibility. And that's something that we've learned over the last several years. When I was first introduced to the device and the technique, it was felt at 40 degrees flexibility. So if curves 60 degrees and it bends to 40 degrees, it's probably okay. I think we're seeing now with our results that it's much better if the bending or the stretching goes to less than 30 degrees. So right now it's single thoracic or single lumbar curves, 35 to 60 degrees, with bending or stretching to 30 degrees or less. There's also the kyphosis is looked at as well. So on the side profile, the thoracic kyphosis can't be more than 55 degrees. So those are the main indications for Apifix in the United States through FDA.
Okay. Now I will be speaking to Dr. Larson, who is one of the Mayo centers, and she's excited. I'm going to ask her about that, the process as well. I'm speaking to Dr. Lone, who's very excited as well, because he's hopeful that perhaps they can start working on that this month. So he said hi, by the way.
Okay.
No,
I say hi back to both of them, actually. And, you know, as you know, Dr. Noelle Larson, she performed with her partner, Dr. Todd Milbrandt, the first Apifix in the United States at the Mayo Center in Rochester, Minnesota, towards the end of June. And it's been great sharing my results and my technical kind of pearls and pitfalls I learned over the years with her and her partner. And I think it really shows the dedication of the surgeons that are interested in this technique, the extent to which they'll want to get as much information as they can about this technique. So I tip my hat to Dr. Larson and Dr. Milbrandt for learning so much about it. I've been on conference calls with them, I spoke to them in person, and been able to share a lot of my cases, the successes and the ones that I've learned from with them. And I've even able to help support them around the time of the operation. So it's really exciting that really thoughtful surgeons at the Mayo, other surgeons very thoughtful like Dr. Lahner as well, who's also been helping develop this technique over time. From my perspective, it's really exciting to see my colleagues that I really trust and think very highly of that are evaluating this as well. It's a little bit lonely being the only North American surgeon for 3 years doing the technique, knowing that you know, there'll be some eyes, you know, on me and ultimately how my patients do. And I want my patients to do well, because I always want my patients to do it as well as they can. And I want to be doing the right thing that I can for them. And so anything I've learned over the years, I'm trying to pass on to other surgeons such as Dr. Larson and Dr. Lahner.
No, that's excellent, because if they're excited in it, you know, they're excited about it for a reason, obviously. Now, a couple questions I have for you, because I believe with the FDA approval, they are limiting it, like you said, to AIS, but to perhaps a Sanders 5. Is that correct? Or do they have flexibility in terms of the testing?
Right. With the Apifix?
Yes.
Oh yeah, great question. We hadn't talked about that. And it doesn't matter what the Sanders score is or the RIS or sign. It can be done in patients who are mature. And that's where kind of my philosophy is a little bit different between Apifix and VBT. I think VBT is primarily growth modulation where you need to have a lot of growth remaining. I think Apifix, we've got some early results that it might be growth modulating, but it doesn't have to be growth modulating. So it can be performed in patients that are RIS 4 or 5, which is fully skeletally mature, and it could be mature by the Sanders scale as well. So it's irrespective of what their skeletal maturity is. And right now it's just kind of arbitrary in terms of age for adolescents rather than adults. That's the population to be studied. That might change over time.
Okay.
There's a study in Europe looking at utilizing it in children under the age of 10. And I think Professor Floman in Israel may have performed the surgery on a few adults. Right now in Canada and the United States, I don't think we're anywhere close to that, but there is potential in the future. So again, it doesn't have to be for growth modulation, which is another uniqueness about it as compared to VB.
Okay. That's with the study that they're doing in the States for the 200 patients. So because there's no Sanders parameter, what do you expect them to be? What's the age group you expect those patients to be limited to?
I think the range will likely be about 10 years of age to 18 years of age. Okay. And I think the mean age is probably going to be 13, 14 years.
Okay. Now, another question I had with respect to the Apifix is that with VBT, it's very difficult for some high thoracic curves in terms of not being able to go above T4 because of anatomy. Is Apifix able to span those areas that VBT can't get to?
Yeah, it is able to span higher than that. I'm trying to think if I've done any surgeries where I've gone that high. I've certainly gone as high as T4, and I can't think of any reason that you can't go a little bit higher. One thing to consider though is if you're getting more correction over time and it's going up as high as T2 or T3, that might affect the balance of the shoulders afterwards. That might change. So one thing to consider, but technically it's possible to do it. And I'm going to backtrack just for 1 second because the way I think about the Apifix, with the FDA approval, it's all kind of lumped into these are the indications. But if you think about the different types of patients that it could be used on, it can be used in the kids under the age of 10, so as a early onset scoliosis device, similar to magnetically controlled growing rods. That's not part of the FDA or the Health Canada approval. That's just in Europe. So that's one population, and that's very early in its development. But the other two are approved in Canada and the US. And they're both variations on the same theme, and they fall within those same FDA indications. And the company's kind of dream is that the Apifix can be used as an internal brace, so an alternative to bracing. Remember how we talked about the vertebral body stapling overlapping with the bracing criteria, and to do an anterior surgery without even offering somebody a brace, I wouldn't do that. I think I'm always going to offer a brace, that's for sure. But if there's a safe, straightforward posterior approach that you can use as an alternative to bracing, such as the Apifix, I think to me that's a much safer, much more straightforward alternative to bracing. So I think the company's number one kind of indication over the years is a safe, effective internal brace. So that might be a patient that might be a RIS 0 or those low Sanders scores that we talked about, with a curve that's, 35 or 40 degrees. I think those patients, this device will work quite well. I think that's where it'll be very, very effective. It might even show some growth modulation, time will tell. Then the other population is an alternative diffusion. So those might be the patients that are a little bit older, 14, 15, 16 years of age. And usually their curves are going to be a little bit bigger, 50 to 60 degrees. And that's also within the FDA indications. And I think very useful in that scenario. But the company's dream is that it's an internal brace that maybe even if you take a 35 degree or 40 degree curve and you put in the Apifix and it stays in place for 2 or 3 years and the curve is down to 15 degrees, well, maybe it can come out and the scoliosis stays at 15 or 20 degrees and then the patient doesn't have any implants in place. There's no worry about it breaking or causing arthritis in 10, 20, 30 years. But again, that's all kind of theory, and that's the goal, that's the objective that we're working towards.
That was my next question, if it could be removed once they hit maturity. Okay.
Yeah, that's we don't know yet. Theoretically, and there have been some patients in Europe and in Israel where the device has been removed for a variety of reasons, and for the most part, the scoliosis has not changed with follow-up. Again, I think it's too soon to say. I have not removed it in any of my patients yet. I don't have that confidence yet. I think we need more study before we're able to do that.
Now, when you actually do the surgery, and with VBT, I think in general, to take advantage of growth modulation, most surgeons are looking perhaps for about a 50% correction, then with growth, maybe another, 20, 25% over the next couple of years. What's the rationale or the strategy with respect to Apifix in terms of how much correction do you go for initially, and how much correction do you have post-surgery with the ratcheting system?
Yeah, another fantastic question. You've done your homework. It's awesome. So there's kind of two philosophies on this, and the original philosophy and the whole reason I have the ratcheting and expandable part of the Apifix rod is that you get a bit of correction in the OR, and then with the patient doing the exercises afterwards, you get a lot more correction. I think the results that I have looked at might be between 3 degrees and 5 degrees of further correction afterwards with the ratchet mechanism. And our variability with measuring X-rays is 5 or 6 degrees. So is that really significant or not? I don't know. There's definitely it's statistically significant. Whether it's going to be clinically significant, that's to be determined. The other philosophy and what I subscribe to is try to get as much correction in the OR as I can and not rely on the ratchet afterwards. Look at that as a bonus. If you get some more afterwards with the ratchet, that's fantastic. Now that might be different in the younger kids that have a lot of growth, because as they grow, they can ratchet on its own. But in those teenagers that it might be an alternative to fusion, they probably don't have enough growth to make that ratchet much over time. So when I do the procedure, I use it with some traction in the operating room to try to get as much correction as I can. And I try to, distract that ratchet mechanism, probably about halfway to full to try to get it correct as much as I can on the table. So two schools of thought. And I think more and more of the evolution, I think, is more towards getting more correction on it in the OR.
Now, with the ratcheting system and the actual lengthening of the rod, how does that work? Is it when it ratchets, it lengthens at the same time? And in terms of a child that's still growing, it extends automatically? How does that work?
Yeah, it's designed that if it's fixed at one end with the 2 screws and fixed at the bottom with the 1 screw, as the child is growing and the spine is getting longer and taller, the spine wants to move this way as it's growing, and as it does, that the telescopic rod moves with it. And if it moves, I forget the exact number, we'd be talking millimeters or fractions of millimeters movement, then it clicks, the ratchet clicks, and then holds it in that position so it doesn't recoil back. So you grow a little bit, it extends, it clicks to hold that position. You grow a little bit more, it grows, it clicks to hold that position, etc. That's the goal of it. In the more mature patients who don't have very much growth, they are instructed to do specific physiotherapy exercises, Schroth type of physio exercises that as you are kind of stretching the spine a certain way, that also will elongate the spine and might have that same effect where it extends, ratchets in position so it doesn't collapse back again. And anytime the spine gets taller, that straightens the scoliosis a little bit.
Okay. I was wondering if you could just two more questions. In terms of flexibility, how would you, what are the ranges of motions that, have you noticed that there is any reduction in flexibility, like flexion extension, rotation, lateral bending with Apifix?
Yeah, with the Apifix. So it's been studied in the lab. It has not been studied clinically yet. Same with the VBT. There are some ongoing studies right now, and I think you'll be talking to some surgeons that are evaluating motion. They might be able to give you a sneak peek at some of those results, but there's been nothing published in patient populations yet on Apifix or VBT. What's been evaluated in the laboratory setting on biomechanical engineering type tests on an animal model and cadaveric model is that there is much better flexibility maintained with the Apifix as compared to a fusion model. Really no effect on axial plane rotation, and it's maybe about a 20% decrease in flexion extension and side bending. I'd have to double check the exact numbers.
Sure.
But it's not perfect in an animal model with flexion extension or lateral bending, but it is significantly better than a fusion model where you may lose upwards of 80% of some of the motion.
Okay. Now, last question. If you're going to look into your crystal ball in 10, 15 years' time, what do you hope to see in terms of possible non-fusion solutions for scoliosis?
Yeah, a wonderful question that I think that it takes so long to develop an idea from a theory to developing the device to ultimately having some testing in an animal to clinical trials, etc., where we've seen that over 20 years for VBT. So I think in another 15 or 20 years, I think that's what we're going to be looking at is a more refined VBT, a more refined Apifix type technique. I think there will be some modifications potentially in the materials that are used, better ability to predict a patient's remaining growth, and better ability to predict the timing of the intervention to harness that growth. In terms of newer techniques that might kind of be the next generation beyond that, there's some early work in Holland. We're looking at a spring-loaded system, what's called the SDS, the spring distraction system. And that's been used in some clinical trials early on in Europe, and that shows some potential as well, where you have that kind of internal sort of distraction where you get more correction over time. But I think ultimately in 15, 20 years in North America, I think we'll be looking at more refined Apifix, more refined VBT, maybe a resurgence in stapling. Stapling is less technically demanding and I think less risk of complications compared to VBT. I think as the design and the metallurgy improves with the stapling, it may make a resurgence over time. But I think I think these techniques that we talked about today are here for the long term, but I think there's lots of room for improvement. I wish I could say that they're all perfect right now, that they're not, and that goes along with innovation and product development, just like a fusion for scoliosis. Paul Harrington's initial device design in the 1950s, we still do posterior spinal fusion and instrumentation. And I still do a heck of a lot of it because most patients don't meet the indications for these other fusionless techniques that we talked about. But the way we do an instrumented fusion for scoliosis in 2020 is very different than how it was performed in 1960, 1970, 1980, even compared to 2000, 2005. It's remarkably different in terms of how we do it. So I think there's a lot of refinement in these techniques that we talk about today. I think that's what we'll be looking at in 15 or 20 years. I don't think VBT will be, a flash in the pan. I think we sometimes have these debates at meetings, and these are healthy debates where you have some surgeons that aren't, don't fully believe in that innovation and, don't think it's going to work. And that's fine. You need to have that healthy debate and controversy and discussion. And it's always very respectful. And I think that's a topic of conversation is VBT here to stay? That might be the talk, the title of a symposium that we have at the Scoliosis Research Society meeting. And my belief, and I think all the other surgeons you're talking to would have that similar perspective that, yeah, it is here to stay. It might be interesting for you to also talk to a surgeon that maybe thinks the contrary, just to get another opinion on it. And then same with Apifix as well. And I think Apifix is a little bit newer than VBT. And I think that it's here to stay as well.
Okay. On that note, thank you so much for your time. Very educational, and I'm sure the viewers are going to love all the details. Okay. Thanks
Awesome.
again.
Well, thanks for having me. I really appreciate it.
Okay. Have a great day.
All right. You too.